I'm Peter Block for On the Scene here in Chicago at ACC.16. Standing next to me is Marty Leon. If anyone does not need an introduction, it's Marty. Marty has just talked about the Partner 2A trial, TAVR in intermediate risk patients. Marty, TAVR has come a long way in the last 7 years. So this is now the final data out of Partner 2A. Tell me what Partner 2A was, first off, for everybody out there, and tell me then what you found.
Peter, thank you very much. Partner 2A was a labor of incredible effort and love. It is the largest randomized trial in the history of valvular heart disease. We looked at patients with intermediate risk, which meant they had about half the STS score that we had originally seen in the Partner 1A trial. So these were still somewhat elderly patients, but they were certainly not as high risk as in the previous studies. We randomized 2,032 patients equally between surgery and the SAPIEN XT valve system, which is really one generation behind, and we followed all of these patients out for 2 years with a primary composite endpoint of all-cause mortality and significant strokes that was carefully adjudicated. Top-line results were that TAVR was non-inferior, similar to, point estimates slightly better than surgery for the primary endpoint. When we looked at the transfemoral subgroup, which was 76% of the patients, it was statistically significantly better than surgery with a p-value of 0.05, and then in the as-treated group, 0.04. So if you were somebody who was a candidate for transfemoral TAVR, then you did better than surgery for the hard endpoint of death and stroke.
Let me just interrupt, Marty, because obviously that brings up the whole issue of the core valve having shown that it was a little bit better initially. So this is probably supportive and good news, not for one versus the other. That's not the point, but for TAVR in general.
Absolutely. This is not so much a device-specific observation. I think the entire field of TAVR clearly is evolving. More experienced operators, better equipment, better case selection, better imaging. I think everything is really combining to achieve better results in our patients.
Okay, now XT is still not the best valve that's around. I know that because we've used the new valves as well. What do you see going forward here, Marty?
Well, SAPIEN 3, as you know, is been around for about a year now. And tomorrow we're going to present the results looking at the SAPIEN 3 intermediate risk patients in a very careful propensity score analysis versus surgery, and you'll see the results tomorrow. Certainly we're very encouraged that SAPIEN 3 represents a whole new level of quality from the standpoint of a lot of hard and soft endpoints.
Okay, so on balance, TAVR's come a long way. We now have intermediate risk patients. We have certainly non-inferiority and possibly even a little bit better outcomes with TAVR. Looking forward, do you see TAVR going down to STS scores of 1, 2, and 3? Everybody asks you that. Give me the short answer.
I think the short answer is that risk profiling never made much sense to me. The arbitrary differentiation of risk categories, really, I think at the very beginning when we had a high-risk procedure with a lot of complications, it made sense. But now that we've already demonstrated 30-day mortality rates of 1%, and 30-day stroke rates of 1%, I think risk is going to be less part of the equation, although we are doing a low-risk study. So in the future, I expect that those patients that clinically and anatomically that would be good candidates for the transcatheter technique, barring anything unforeseen in terms of very late durability, I think it's going to be preferred and probably is going to be not just the alternative, but it's going to be the choice that most patients and physicians are going to gravitate towards.
So there you have it from the horse's mouth. Thank you, Marty.